Welcome back to the Deep Dive. So you give us a stack of sources on a topic that can feel really overwhelming, diabetes mellitus.
It's a big one.
It is. But instead of letting all those clinical criteria and, the medication lists just wash over you, we're going to act as your guides here. We're going to cut right to the core of it all.
That's exactly the mission. When you look at diabetes, the sheer volume of information can be, well, dizzying. We're here to extract the clearest facts.
Right.
To show you how physicians classify these conditions, how they make a diagnosis, and how they manage them today. The focus is on clarity.
Exactly. This is your comprehensive lesson. We're unpacking the fundamental differences between type 1, type 2, and the trickier monogenic forms. We're decoding the numbers and looking at how treatment is really shifting.
Okay, let's unpack this. And we have to start at the very beginning with classification. Because if the causes are different, the treatments are different. Defining the type is like step one, right? It has to be. If we're approaching this structurally, you have to start with the fundamental causes. That etiology, it dictates everything that follows. We hear type 1 and type 2 all the time, but what's really separating them?
Okay, so let's start with type 1 diabetes mellitus, or T1DM. This is the relative rarity. It's only about 5% of all cases.
And T1DM is, at its heart, an autoimmune disaster. The sources really highlight that it's strongly associated with certain genes, specifically HLA-DR3 and DR4.
Okay.
And the core problem is that the body's own T cells, they go in and destroy the pancreatic beta cells. This destruction is fast, and it leads to an absolute insulin deficiency.
So the body just stops making it completely.
It literally can't make the insulin it needs.
And the patient profile, I imagine, reflects that kind of severe, immediate breakdown.
It does. They're typically young, usually thin, and the most critical clinical detail the sources mention is the presence of circulating autoantibodies in 80 to 90% of cases.
Things like GAD or anti-insulin antibodies. So is the presence of those specific autoantibodies, is that the single most definitive lab finding? The thing that rules out type 2?
It is the gold standard differentiator, yes. And because their beta cells are destroyed, insulin dependence is mandatory from day one.
And that lack of insulin means they're at a high risk of something called diabetic ketoacidosis, DKA.
A very high risk.
Wait, can we just pause on DKA for a moment? For anyone listening who might not know, what exactly is DKA?
It's a life-threatening complication.
Yeah.
Basically, without insulin, the body can't use sugar for energy, so it starts burning fat instead. This process produces something called ketones, which are highly acidic.
Okay, so you get a buildup of acid.
An extreme buildup. The accumulation of these ketones makes the blood dangerously acidic, which requires immediate intensive care to correct. It's really the signature crisis of T1DM.
Got it. Now let's contrast that with type 2 diabetes mellitus, T2DM, which is the overwhelmingly common form.
T2DM is different on, well, every level. It's multifactorial, polygenic, and it actually has a greater heritability than type 1.
Interesting.
And the key mechanism isn't destruction, it's resistance.
Resistance.
Think of insulin as a key trying to open a lock on the cell, but in T2DM, that lock is, rusty or glued up.
So the key doesn't work as well.
Exactly. Over time, the pancreas has to work overtime, overproducing insulin until the beta cells just get exhausted and start to fail. That leads to a relative deficiency.
And this corresponds to that classic patient profile. Older and often overweight, over 90% of T2DM patients fit that description, right? They often have other issues like hypertension or fatty liver disease.
Precisely. It's all part of that metabolic syndrome cluster.
Yeah.
And because they initially still produce some insulin, their insulin dependence is often late or sometimes not required at all. The risk of DKA is much lower.
Much lower, but not zero.
Not zero, no. Especially during times of extreme stress or a bad illness.
Okay, before we move on to diagnosis, we have to touch on that third, trickier category, MODY.
Ah, yes, MODY, monogenic diabetes.
Yeah.
What's fascinating here is that MODY is rare, and it's caused by a single gene mutation.
A single gene.
Yes, and the sources emphasize that its key differentiator is the family history. It often affects 2 or more generations. These individuals can present clinically a bit like type 1. They're young, not necessarily obese, but their problem is inadequate insulin release, not autoimmune destruction.
So if you have a young, non-obese person with diabetes, but you can't find those type 1 autoantibodies, and maybe their mother and grandmother also have it, that's when you start thinking MODY.
Absolutely. And because it isn't autoimmune, they rarely require insulin, and they have a low risk of DKA. Then, of course, there's that secondary causes category to remember.
Right, things like chronic pancreatitis or hormonal issues like Cushing's syndrome.
Exactly. Those are things that can cause diabetes but don't fit into the main types. If a patient doesn't fit the classic profile, you have to dig a little deeper. If we connect this to the bigger picture, this distinction between T1 and T2 is so critical because it tells us immediately whether the patient needs insulin just to survive or if we can start with drugs to help their body use the insulin it already makes.
That clarity is vital. Okay, let's shift gears to diagnosis. So if the cause dictates the treatment, the next logical step is confirming it. What are the non-negotiable numbers we need to know?
Diagnosis really relies on hitting specific thresholds on three main tests, as defined by the American Diabetes Association, the ADA.
Okay.
And this is important. Unless the patient is, clearly symptomatic with sky-high glucose, confirmation usually requires 2 abnormal readings on separate days.
Let's break down the most common test first, the HbA1c.
Right, the HbA1c or glycated hemoglobin. Diabetes is confirmed if it's 6.5% or greater. The warning sign, what we call prediabetes, is in that 5.7% to 6.4% range.
Okay, 6.5 is the magic number there. And what about the standard fasting plasma glucose, or FPG?
For the FPG, DM is confirmed if it's 7.0 millimoles per liter or greater. The prediabetes range here is 5.6 to 6.9. And just remember, FPG requires fasting for at least 8 hours.
Usually overnight. And the last one is the oral glucose tolerance test, the OGTT.
That's the one that checks how well the body processes a sugar load. The patient drinks 75 grams of glucose, and if their plasma glucose level is 11.1 millimole or greater at the 2-hour mark, that confirms diabetes.
Now let's go back to the HbA1c for a second. You mentioned it's the most common screening tool. How does it actually work, and when can we not trust it?
It measures the amount of glucose that gets stuck to the hemoglobin in your red blood cells. And since red blood cells live for about 90 to 120 days, the test gives us this great rolling average of blood sugar control over the last 3 months or so.
It's a long-term picture.
A very reliable long-term picture for most people.
But there are situations where it's not reliable, right?
Yes. Any condition that affects the lifespan of red blood cells, like severe anemia, chronic kidney disease, or certain blood disorders like thalassemia, can skew the result.
How so?
Well, if a person is constantly making new red blood cells, they haven't been around long enough to get a lot of sugar stuck to them, so the average sugar reading will look artificially low.
Ah, okay. So in those cases, you'd use something else.
Exactly. In those specific cases, physicians would switch to an alternative test, something like fructosamine.
Here's where it gets really interesting, because diagnosis isn't just about the numbers on a lab report. It's about recognizing the systemic damage that's already happening. We're talking about the physical exam.
Yes. This is so important. Diabetes is a vascular disease, and the complications can show up everywhere, even before severe symptoms do. We look for signs of damage in specific places.
Like on the skin.
On the skin, there's a very distinct sign called necrobiosis lipoidica diabeticorum. It's a kind of chronic skin plaque.
And I know the feet are always checked first. Why are the feet so critical?
The feet are where 2 major complications come together. Neuropathy, which is nerve damage leading to sensory loss, and vascular damage, which is poor blood flow.
Right.
So we check for ulcers, for deformities, for any sensory loss. I mean, if a patient can't feel a small stone in their shoe, that can lead to an injury, which becomes an ulcer, and potentially an amputation. It just underscores that we're looking at widespread damage.
That leads us perfectly into management. Once DM is confirmed, the approach has to be really individualized.
Absolutely. Individualized glycemic control is the core philosophy. We tailor the target HbA1c to the patient. For a young person, recently diagnosed, we'll aim for really strict control, maybe below 6.5%.
But for an older patient?
For an older patient with advanced disease and maybe heart conditions, we set a less stringent target, maybe 7.5% or 8%, because for them, the risk of a dangerous hypoglycemic event is actually worse than slightly high blood sugar.
But regardless of that target, the foundation for everyone is the same, right? Lifestyle management.
It's the non-negotiable foundation. Diet focusing on complex carbs and low fat, regular aerobic exercise, smoking cessation, and limiting alcohol. These things can have a huge impact.
How much of an impact are we talking about?
These interventions alone can lower HbA1c by 1% to 2%. That could be enough to delay or even avoid medication entirely for some people.
Okay, so let's move to the pharmaceutical side of things for type 2, starting with the classic first-line treatment, metformin.
Metformin from the Big 1/8 class is the absolute workhorse. Its mechanism of action, its MOA, is essentially to tell the liver to just chill out. It reduces hepatic glucose production.
It stops the liver from dumping too much sugar into the bloodstream.
That's it, especially overnight.
And its main selling point, besides just working well,
It's weight neutral. That's a massive benefit for T2DM patients who are often struggling with obesity. The side effects are mainly GI upset and rarely lactic acidosis.
And there's a big clinical rule for it, right, with contrast dye.
Yes, a very important one. If a patient has impaired kidney function, metformin has to be stopped 48 hours before any procedure involving contrast dye to prevent further kidney issues.
Got it. Next up, the sulfonylureas, like gliclazide.
These are older drugs that basically force the pancreas to work harder. Their MOA is to increase insulin secretion by directly stimulating the beta cells.
But there's a big trade-off.
A huge trade-off. They carry a high risk of hypoglycemia because they just keep pushing out insulin, even when sugar is low, and they often cause weight gain.
Now let's talk about the modern classes that have really shifted the whole philosophy, starting with the SGLT2 inhibitors like empagliflozin.
If we connect this to the bigger picture, the goal of treatment now is not just lowering sugar. It's about protecting the heart and kidneys first. And SGLT2s, they really embody this shift.
Okay, so how do they work?
Their MOA is incredibly simple. They block the mechanism in the kidney that reabsorbs glucose. So you pee out the excess sugar.
And the massive benefit here is that organ protection.
Exactly. They show major benefits in patients with chronic kidney disease and heart failure, even if they don't have diabetes. The main side effects are infections, UTIs, and mycotic infections because of all the sugar in the urine.
And there's a surgical consideration for them too.
Yes, they must be stopped 3 days before major surgery due to the risk of different kind of acidosis.
Finally, the GLP-1 agonists, like liraglutide.
These are the incretin mimetics. They mimic natural gut hormones, and they have a fantastic MOA. They only increase insulin secretion when blood sugar is high.
Which means the risk of hypoglycemia is very low.
Very low.
Oh.
And their huge advantage is not only being cardioprotective, but also causing significant weight loss, which is, a game changer for T2DM management.
That move from drugs that make you gain weight to ones that help you lose it, that feels like a revolutionary change.
It is. The decision-making process now starts with, does this patient have heart disease or kidney disease?
Mm-hmm.
If yes, you start with an SGLT2 or a GLP-1, sometimes even before metformin, because that organ protection is just so powerful.
Which leads us to the next level of management, insulin therapy. When is insulin actually indicated?
Well, it's required immediately for all type 1 patients, of course. For type 2 patients, it's when oral meds just aren't hitting the target anymore. Usually if the HbA1c is about 1.5% to 3.5% above their goal.
And with insulin, the speed is the key concept here. Can you simplify the different categories for us?
Absolutely. Think of insulin in 2 functional groups, basal and prandial. Basal insulin, like glargine, is your long-acting background insulin. It provides a steady level over 24 hours to keep the liver in check.
And prandial is for meals.
Prandial is your meal coverage, yes. That's the fast-acting dose to cover the big spike in glucose after you eat. We have rapid-acting insulins, which kick in within 10 minutes, so you take them 15 minutes before a meal.
Okay.
And then there are short-acting insulins, which are a bit slower. They take about half an hour to start working, so you take them 30 minutes before a meal. A patient needs both types to mimic a healthy pancreas.
Now, to make this even more complicated, the sources describe 2 phenomena that can mess up overnight blood sugar control. Can you clearly differentiate the dawn phenomenon from the Somogyi phenomenon?
They both result in high morning sugar, but the cause and the fix are total opposites.
Okay.
The dawn phenomenon is a natural thing. Between 2 a.m. and 8 a.m., the body releases hormones like cortisol. It's the body's natural alarm clock, priming you to wake up by raising blood sugar.
So if the sugar is climbing naturally overnight, the fix is...
You need more basal insulin to counteract that natural morning spike.
And the nocturnal hypoglycemia or Somogyi phenomenon?
That's a rebound effect. This happens when the pre-dinner insulin dose was too high, causing blood sugar to drop dangerously low overnight. The body panics and floods the system with hormones to save itself, causing a rebound high sugar by morning.
So if the sugar dropped too low overnight, the fix is actually to reduce the evening insulin dose.
Or add a snack before bed, yes. It just shows that management is dynamic, not static.
Especially during stress.
You mean like when a patient gets sick? Precisely. When a patient has an infection, what we call intercurrent illness, their stress hormones cause insulin resistance to skyrocket. Their insulin needs can go way up. They have to monitor their glucose constantly and adjust their doses aggressively.
And what about for major surgery?
That requires a very specific protocol. We stop oral meds days beforehand. Since the patient is fasting and under stress, their blood glucose has to be managed very closely with a continuous infusion, usually a dextrose potassium insulin or DKI pump.
Wait, why dextrose and potassium? If you're trying to lower the glucose, why would you give them sugar?
That's an excellent question. We give dextrose to prevent the patient from becoming hypoglycemic during that long period of fasting. And we add potassium because when insulin drives glucose into the cells, it pulls potassium in with it.
Which could cause dangerously low potassium levels in the blood.
Exactly. So the DKI pump is this fine-tuned balance of all three to keep the patient safe during a really high-stress event. So to synthesize all this, managing DM requires 1. Accurate classification, T1, T2, or MODY. 2. It demands precise diagnosis using those hard and fast criteria. And 3. It requires a stratified, dynamic management plan that balances lifestyle, cardioprotective drugs, and, if needed, the precise timing of insulin.
It's a vast topic, but by focusing on the cause, the criteria, and that big shift in treatment philosophy towards organ protection, it becomes a lot more manageable. Thank you for making all that so clear.
This brings up an important question for you, the learner, to think about. Given the strict criteria we use for DM diagnosis, how often do physicians test for the less common secondary and monogenic causes, like the genetic syndromes or pancreatic disease, when a patient doesn't fit the classic type 1 or type 2 profile? And what are the long-term implications when those rare diagnoses are missed? Think about that ripple effect a misdiagnosis can have on everything that follows.